No conflicts of interest. All right. This is an 82-year-old patient, ambulatory, good, basically good health, on multiple drugs to keep her in good health, who says at the end of a total skin exam for skin cancer that my legs itch. What does the patient have? Xerosis, just plain dry skin. And you can tell that from these sort of angulated cracks. And what's that called? Eczema croquelé. It's like cracked porcelain from the French. So that's what this patient has. What's the most important intervention? What do you need to do? Moisturize, 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 moisturize. Don't wash. No soap, less soap. Soap substitutes, things like Cetaphil. There's another soap substitute that's available. Cetaphil is the one everybody knows about. It's a non-detergent cleanser. There's another one that's called Aquanil, which I like because it reminds you what it is. No water. Aquanil. And you just put it on. You don't use water at all. You rub. It kind of foams. It's a modest cleanser, but it'll get rid of most grime and grit. And then you just wipe it off with a towel. Aquanil, Cetaphil. So most important intervention is moisturizer. I gave you lists of moisturizers when we talked about the itchy patient. And remember, the ones with ceramides are probably the best because that's the most natural moisturizer. Would it be reasonable to do any lab tests in this patient? Yes or no? Not necessarily. But remember that dry skin can be dry skin because you're getting older and you're not producing enough moisturizer. Maybe you live in a cold environment, go in and out of heated places, etc. But also remember, dry skin can be precipitated or exacerbated by things that dehydrate you. So I would at least ask if there wasn't a history. Obviously, in a polypharmacy patient, they're being followed adequately by some healthcare provider. But if this patient just came in and looked like this, I'd at least ask about frequent urination, something that might suggest diabetes, older individual. And I might at least think about thyroid function, because dysfunctional thyroids can lead to dry skin. So I'd think about it. But in this particular patient, probably not necessary to do a whole lot of lab testing. Just slather down. How often should one apply moisturizer? Once a day, 2 times a day, 3 times a day? Whatever it takes. That's the answer. You know, for most people, 1 or 2 times a day is appropriate. Early in the day and then later in the day or early evening would be sufficient. They don't have to moisturize every single minute. That's like overkill, but a couple times a day is probably sufficient. Okay, here's a patient who comes in for this spot. Asymptomatic, small, firm papule on the nose. In a southern state, what's the most likely diagnosis? Basal cell carcinoma, okay. So, could be, but anybody think about anything else it might be? Trichoepithelioma, solitary trichoepithelioma. Excellent choice from what we discussed. Anything else? Milia. Milia is reasonable. It's not quite as, it's kind of hard to tell from a picture. It's not quite as white or quite as deeply embedded, but that certainly would fit with what we talked about yesterday. Those 2 things, milia, solitary trichoepithelioma, and basal cell carcinoma. So, anything else?
Is that the lanugo?
Is that what?
The lanugo, the hair on the
Oh, lanugo, no, that's really tiny bits of hair. No, that's not the hypertrichosis. Okay, so this is something we didn't talk about yesterday because there was only so much time and so many things to talk about as it is. And this is called an angiofibroma. So it's fibrous tissue with some blood vessels in it. They're small, sometimes they're flesh-colored, but they might be reddish-brown. On the nose, it's called a fibrous papule of the nose. It's a totally benign event. It's usually solitary. When individuals have multiple of these, then it's usually associated with some hereditary syndromes, which we'll discuss in just a second. What would you do with this? Leave it biopsied, of course, because it would be really hard to say for absolutely certain that that's not a basal cell carcinoma. So for something like this, a shave biopsy would be reasonable. Just take it off flush with the base, obtain hemostasis, see what it is. If it's a basal cell, you might know even from your biopsy because it'll feel kind of soft. If it feels harder, then you would think about this fibrous entity, angiofibroma. Okay, here's a patient with 4 of them. Notice in these, compared to the other one, these are a little redder. See the red cast to them, red-brown, as opposed to just flesh color. So remember, trichoepitheliomas are exactly the color of the skin in which the patient who's presenting with them is, and that milia are always bone white. So these wouldn't be milia, these really wouldn't be trichoepitheliomata. Look at that reddish-brown cast to them. They're firm, they're small, they're papular, they're on the face, on or near the nose. These are angiofibromas, benign, with multiple of them. Could these be basal cells still? Sure, people can have multiple basal cells, but it's kind of unlikely unless you have a syndromal propensity to develop basal cell carcinomas. Okay, this patient has lots and lots of those reddish, brownish, firm, small papules in the center of the face. Multiple angiofibromas means something. So this patient has a disorder. Does anybody know what that is? Yes. So you should get free tuition next year. Tuberous, if I could do it to you, I would. Tuberous sclerosis. So tuberous sclerosis is an inherited disorder or a spontaneous disorder, more spontaneous than our hereditary, and you see multiple angiofibromas. On the skin, you can also see shagreen patches, which are kind of fleshy, firm patches that have multiple little bumps on them. You can see fibromas under the nails, particularly on the feet. If you shine a light behind the teeth, you will see pitting of the teeth, which is a very interesting and specific indication that the patient has tuberous sclerosis. Almost nothing else does that. And of course, the big problem is not the skin. The skin is a way to make the diagnosis. The big problem is what with tuberous sclerosis? You have seizures, you may have learning disabilities, you may have kidney or lung lesions, so it's a multi-system disease. This is not all that uncommon. It's about 1 in 6,000 live births in the United States. There are about 40 to 50,000 individuals in the US who have this disorder, 1 million worldwide, and it's due to mutations in one of 2 genes, TSC1 and TSC2. Multiple angiofibromas. A single angiofibroma, usually on the nose or near the nose in an older individual, has nothing to do with this disorder. This disorder is multiple of these, particularly on the face. By the way, there's no need for someone to look like this the rest of their life either, because these actually do respond quite nicely to certain laser interventions, and you can destroy these bumps and they're gone forever. So it's nice to know that this can actually, part of this syndrome that's distressing can actually be treated. Okay, and we've talked about this. You can also see multiple angiofibromas in a couple of other odd syndromal conditions, but primarily in tuberous sclerosis. Okay, this is my favorite of what we're going to do this morning. This is a 25-year-old. He had full hair on his scalp, was in good health, became kind of nauseated, and he reported to the emergency department of our major teaching hospital. primarily because of intractable nausea. But when his review of systems was done, he also said he had pain in the tips of his fingers and the tips of his toes. He had double and blurred vision. He had a tachycardia. Now, tachycardia in an emergency room, every time I've been in the emergency room, I think I have tachycardia too, because I'm wondering what's wrong, what are they going to do to me? But also hypertension. He's a very young person, no history of prior hypertension. In fact, no family history of any cardiovascular disease. Because he had blurred and double vision, ophthalmology came to see him, and they said, oh, his optic disc isn't right, he's got an optic neuropathy. And because he was complaining about pain in his fingers and toes, the neurologist came down and said, I think they have this person has a peripheral neuropathy. When he was admitted, then he was found to have abnormal nerve conduction studies, and they called us to see him because he has very, very little hair there. So what little hair was there, we pulled, and it came right out with no resistance whatsoever. When I pulled it out, what would I be looking for? What would I do? Shout it out. I can't. Yeah, look at the hair shaft. They were growing hairs. They were anagen hairs. What he has left was still anagen hairs, but he's pretty much lost a lot of everything. While he was in the hospital, he had a neurologic workup, addition to his nerve conduction studies, normal brain, normal spinal tap. Okay, so there's your patient with hair loss. What's suggested by this symptom set? Pardon? Who said? Pheochromocytoma, well, is hypertension, is tachycardia, but the rest of it wouldn't go along with it. Someone else on something over here? Poisoning?
Where does he work?
Where does he work? A good question to ask. He's a teacher. So he's not involved in chemicals, he's not involved in manufacturing, he's not involved in anything where he'd be exposed to toxins. What would one do? What else do you want to know about him? Social history, anything? He's married, no children. He says his marriage is pretty rocky. They're arguing all the time. What's happening to him? Someone's trying to kill him. Yes, he's an anagen effluvium. Remember, when you're losing growing hairs, normal hairs, not resting hairs, and this is an extreme example. I mean, he's lost virtually everything, not quite, but close to. Then you're either getting chemotherapy or you're being exposed to a heavy metal. Lead, arsenic, thallium, heavy metal. So he's got a rocky marriage. He's got these other signs and symptoms. And remember that heavy metal poisoning is often associated with neuropathy, ophthalmologic abnormalities, which he has both of. And then if you throw in hypertension and tachycardia, that actually gives you a nice syndrome that's associated with one of the heavy metals. Anybody know which one it is? It's one we've talked about. Not arsenic. Thallium. So, I mean, it's kind of hard to say, is your spouse trying to kill you? I mean, you have to have some sort of basis to start that. And of course, she's at the bedside and she's being very solicitous and, oh, what's wrong with my husband? And he's lost all his hair and he has all these pains and all that sort of stuff.
What does she do?
She's a teacher.
She doesn't work in a nuclear medicine?
No, she doesn't work in a nuclear medicine plant. But as I said the other day, you can get almost anything you want online if you look long enough and hard enough. Not necessarily in the US, but you can get it from overseas. And you can get it from places like China and India. So, without any controls like you might expect. So, I'm thinking he's being poisoned, and the hypertension and the tachycardia, along with his eye and his neurologic and his hair loss, really spell thallium. So now I want to confirm that. What would I do? You can do hair samples, you can, but it doesn't last very long in skin and hair. So you have him pee in a cup, and you send that off because urinary thallium, most of us don't have thallium in our urine. It's just like not going to happen. But it will filter out there, and sure enough, he had gobs of thallium in his urine. So she's poisoning him, and she got a thallium-containing radionuclide from India, as it turns out, ultimately, and she was trying to kill him. Unbelievable. Unbelievable. What's the treatment for this? Prison, divorce. Yes, yes, yes. You can do chelation. It's not actually terribly good, but you do it the best you can. Basically, the treatment for this is tincture of time. And if you don't die, you'll recover from it, as he did. And it was kind of interesting because this is one of the 3 homicide trials I've actually been able to testify at. So they called all the consultant physicians. You saw hair loss. What did you think? What did you do? What did you recommend? Et cetera, et cetera, et cetera. But
you know how it was resolved, Ted, in terms of...
yes. What happened with the wife?
Yes.
Oh, yes. So she was found guilty of attempted murder. But in the state of Texas, all states have statutes that determine the severity of the punishment, how that's determined, and what else. So the prosecutor, the DA in this case, no, the DA in this case was very interesting. She said attempted murder with a deadly weapon because she interpreted, she wanted the jury to interpret, because you have a higher punishment if your attempted murder is with a deadly weapon. As long as a gun, well, she said, well, thallium's a deadly weapon because nobody's going to be putting thallium in someone's dinner. And they've done that a few times. They've done it with burn victims as well, deliberate burn, mostly in children, where they dunk them in boiling hot water, and ultimately they die or they almost die. Then it's murder with a deadly weapon, and that carries a death sentence. So this was attempted murder with a deadly weapon, and he got 40 years with no parole. He did. She got, yeah, he didn't get, he was already problematic, right? No, she got 40 years with no parole. So she was in her 20s, so that means she'll get out just in time to get Medicare. So, interesting. All right, here's a 40-year-old woman who complained of the bumps on her face, which hurt. And she said they hurt in December, January, and February. And then pretty much they don't hurt too much the rest of the year. I'm in Houston. December, January, and February is winter, end of winter in March. Inferno by April. So it's hurting in the cold. So the other thing she said is, with direct examination, she's not going to tell a dermatologist this, but asking her, she had spotting. She was still having periods. Now that could be normal maybe at 40, maybe if you're starting to enter menopause, but she did admit to that. Okay, what are her facial lesions and what's her risk? Leiomyomas. Notice the color is unfortunately not the best of pictures, but it's kind of that reddish brown. They're like mounds. They're not papules, little round globoid things. They're sort of like mounds with a longer dimension than they are high. So these are leiomyomas. They're the ones that hurt. Remember, angiolipoma, that's fatty tumors with blood vessels in them, but those would be big, deep, very few in number. Angiolipomas, leiomyomas, glomus tumors, which occur under the nails, are the ones that really hurt the most. So this is a painful tumor. It's worse in the cold, which is typical, so it's leiomyoma. So what is she now automatically at risk for? renal cell carcinoma, that's called Reed syndrome. They have leiomyomas on the face. They have leiomyomas in the uterus, which are responsible for their bleeding, and they may have renal cell carcinoma. So you need imaging of the kidneys she had. They were normal. So would you stop there? Would you never re-image her? She should be re-imaged periodically and certainly warned about signs and symptoms that might suggest there's a tumor in the kidney. So these are leiomyomas. Remember, leiomyoma is a knee-jerk, automatic reaction to think about renal cell carcinoma as a risk. Okay. 38-year-old homeless veteran. My small soapbox for the whole meeting is we should have no homeless veterans. That's unfortunate. They've served their country well. Homeless veteran, severe itching, mostly on his ankles. He had some itching elsewhere, a little bit on the arms, but mostly on the ankles. He'd had a comprehensive lab exam a few months before everything was normal, has no systemic complaints. So he's going to get an exam because I'm itching, so you want to look at him. And in the process of removing his clothes, his primary care physician saw this and called me to come to the primary care. This is a true story. Most of these are exactly, I'm presenting them exactly the way they appeared. So called me to come down to prime care and look at this and confirm what she suspected. What do you see? Lice. Those are lice. What kind of lice? Head lice, body lice, or crab lice? Body lice. And where do body lice live? In the clothes, in the seams of the clothes or in the clothes. And you can see with that blow up of the smaller picture that there are lice there. So what's the treatment? Throw away the clothes. Somebody said it. Burn the clothes. You got to get rid of the source. Now, because it is possible, they don't like to live on the skin, but some might be in the process of feeding. In someone who's very hairy, there might be a few that got caught in the hair, particularly on the chest or the arms. So a good shower with something like a loofah, just to make sure that there are none just sitting around there. So a good shower and then get rid of the clothes. Do you need to put any insecticides on this person? No, because they live in the clothes. Treating him is a waste of time. How about the room that he was just in? Well, the VA is a little odd. This patient was seen at the VA, obviously. It's a little odd because you have to seal off the room, and then the environmental people have to come in their hazmat gear and clean the whole room in case there's a stray louse left on the floor somewhere. It is an important consideration that you make sure the room has been cleaned up. But yes, this is body lice. They itch. The person itches because the body louse is feeding, and there are antigens in their saliva that induce that itching. Okay.
It's sometimes difficult to differentiate between like a body lice and scabies.
The distribution is much different because body lice, because they live in the clothes, they're going to bite, they're going to take their blood meal in an area where clothes are in close contact. So you see that mostly the itching is where clothes are literally close. So here, the back, so the axillary lines, the neck, the waist, and that's not typically where you see most lesions. You have widespread erythema and little itchy spots all over in scabies, but the majority of actual lesions are going to be on the finger webs, the wrist. You'll see lesions around the areola in women and on the glans, penis, and scrotum in men. And you don't usually see lice there. So most of the time, even from a morphology, it's not hard. Obviously, if you find an organism, we're going to talk a little more about finding scabies in a second. If you find the organism, they're much different. Scabies is microscopic, lice are macroscopic. Okay, these are benign skin tumors. They're kind of just hanging there. What are they called? This is a little unusual place to find them, usually neck, groin, axilla. like recordons or skin tags, right? These guys, he has skin tags all around his eyes. You could treat these the same way you would treat skin tags anywhere else. Since these are all sort of hanging and big, you wouldn't really want to electrodesiccate them. You'd have to be desiccating a very long time to get rid of them. You would anesthetize and snip them off would be the easiest way to treat these. If you have that little contraption that you can dip in liquid nitrogen and grab them until they're frozen, that's also possible. When you do this around the eyes, he's going to be swollen, so not if there's an important event for the next day or two, but skin tags. What one lab test might you order if he hasn't had this, like, in the last year or two or three? A1C. You want a fasting blood sugar, hemoglobin A1C, probably better. But yeah, you want to make sure he doesn't have diabetes. It's the only thing metabolically that's associated with these. Okay. I'll show you the picture next, but I want you to hear the story. This is also a VA patient, 67-year-old Vietnam War vet, complains of itching in the groin since the war. Okay, Vietnam War was quite a while ago. His medications include metoprolol to suppress a supraventricular tachyarrhythmia and BID metformin to control his modest hyperglycemia. His current A1C is, it's up there, but it's not exactly startling, 6.5. Pulse, blood pressure, normal. Recent metabolic panel, everything normal. He's itching in the groin. He's been itching in the groin since, when was Vietnam War? Till now. So, two things you might think of. Tinea cruris. Anything else? Maybe his history is a little wrong. I think I heard it over there. Lice, pubic lice, could be. For 30 years, probably not, but it's a possibility. So there's a bacterial disease that looks a very much lot like tinea cruris, and that's called erythrasma. Erythrasma, often mistaken for tinea. People will be put on antifungal medicines by mouth and topically forever and ever and ever, and it has nothing to do with fungi. It's bacterial, and it occurs in the groin. Sometimes it occurs in between the toe webs, and if you shine a woods lamp on it, it fluoresces a very nice coral reddish orange or reddish pink. And it responds beautifully to erythromycin or clindamycin, either topically or orally. Okay, so now let's look at the patient. So there's his rash, both sides, upper inner groin. So what might you like to do to this guy? What would you might do to? There's his KOH prep. So he's got fungus. He's got tinea cruris. All right. Put him in the private sector, because in the VA, of course, we're restricted to a formulary. Put him in the private sector. He has good insurance. He can get any medicine you want to prescribe. What's a good antifungal that he can use for only 7 days? Luliconazole. We talked about that the other day. It's expensive. Most insurance plans won't cover it. Mine does. Blue Cross Blue Shield High Option does, but a lot of them don't. But luliconazole, very, very good topical. Once a day, 7 days, he's finished. He has no money, no insurance, can't afford anything fancy, but you can still send him to get an OTC, really, really good topical antifungal. Anybody remember? Lotrimin Ultra, not Lotrimin, that's clotrimazole, Lotrimin Ultra, which is a benzylamine. It's related to terbinafine. It's called butenafine. You have to tell them, circle the ultra, $9 for a gigantic tube, once a day application. Now, I just want to point out one other thing. Antifungal agents are, of course, designed to kill fungi, but antifungal agents also have inherent, some of them, inherent anti-inflammatory properties, regardless of whether they kill fungi or not. It's irrelevant. And experimental ways of inducing inflammation on the skin have been done, and then the antifungals have been put on to see whether it reduces the itching, burning, or stinging, and a lot of them don't. The azoles, all the azoles, clotrimazole, miconazole, econazole, oxyconazole, sertaconazole, luliconazole, none of the azoles have much anti-inflammatory activity except for one. That's ketoconazole, which is also pretty cheap, generic. And ketoconazole is about the equivalent of 2.5% hydrocortisone. However, the other class of antifungal agents, of which there are only 3, naphthene, which is Naftin, it's not available as a generic, terbinafine, which is Lamisil, it's available as a generic, and the one I've talked about, butenafine, those 3 are highly anti-inflammatory. So that if you need quick symptomatic relief, you're better to use one of those are called allylamines, than you are to use an azole. Quick symptomatic relief. They don't itch very rapidly, long before their overt fungal infection is resolved. Okay, this is
Ultra, do you treat for 2 weeks?
ultra 2 weeks. Everything else is 2 to 4 weeks. Luliconazole is 1 week.
Would you comment on lotrazone?
Oh my God. So, you know, lotrazone is a combination of fungus and and steroid. And yes, the steroid helps give you that quick relief while theoretically the antifungal is working, but it can overshadow, suppressing the local T-cell response can overshadow the benefit of the antifungal. And if you use lotrazone, you can end up actually feeding the fungus and making things worse. It's a bad product. I don't like it. If you want to give someone anti-inflammatory relief quickly while you're treating a fungus, use Lamisil or use Naftin, which is naphthene, or use Lotrimin Ultra. You'll get the same effect.
Would you consider using oral Lamisil for that patient?
In this patient, you know, Lamisil, yeah, the oral Lamisil versus a topical agent, let's start short and long term. So short term, no. You could. I wouldn't fault it if you gave him 250 of Lamisil a day for a couple weeks. You'd probably be fine. Just remember that Lamisil terbinafine is not a benign drug. There's a 1 in 54,000 risk of hepatotoxicity, number 1. There are drug-drug interactions. It's metabolized by a different cytochrome P450 system than itraconazole, which has pages of drug interactions. So terbinafine, there are very few drug interactions. Let me mention some that actually are pertinent to our whole conference today. Glipizide and glyburide, not a lot of people are on them these days, but those 2 agents are not metabolized well if you give terbinafine along with them. So then you can have, and it has been reported, hypoglycemia. That's number 1. Number 2 is metoprolol, our favorite beta blocker, may be interfered with in its metabolism. So you can end up with a pulse of 15 and a blood pressure that's unmeasurable. That's actually happened. Another thing that terbinafine interferes with are opiate narcotics, but in a way that's kind of odd. It impairs the metabolism of narcotics so that they don't act. So if someone's taking an opiate post-op or they're taking an opiate on a low dose for some chronic pain problem, they won't get any pain relief. And the other thing that terbinafine does, which is kind of unique, is it causes either ageusia or dysgeusia, loss of taste or funny taste, particularly in women. Don't ask why, I don't know why. So Lamisil by mouth is not a totally benign drug, it's cheap. But if you can use a topical instead of a pill, my philosophy is the fewer pills in life you take, the better off you are. We weren't born with a sign that says, give me a pill. I mean, you're just better off using a topical. Long term, what are we going to do with this guy? Is he likely to have recurrences of his tinea cruris? He's had it ever since he's been in Vietnam. The answer is yes. But where do you need to look? You need to look at his feet, because that's probably the source of his fungus. And there actually have been studies, oh my God, some people had a lot of time on their hands. They cultured shoes in people that have had tinea pedis, athlete's foot, and onychomycosis. They've cultured underwear in people who have tinea cruris, crotch rot, and they found the fungus there. And then you can actually think about a way, putting on your clothes, putting on especially your underwear, or you might get a few little bits and pieces of scale with fungus in them as you're putting that on over your feet, and then you're putting it in a warm, moist area. So people who have recurring bouts of tinea cruris, the source, the root of all evil is the foot. You need to look at their feet. And if they have tinea pedis or they have onychomycosis, fungus of the nail, that needs to be treated, and that's how you stop the cycle. Okay, this is a benign skin tumor. There's a little Q-tip pushed on it, and where is it? It's gone. So what is this called? Venous lake. And where are venous lakes found other than the lip? The ear and lip. Okay. This is what it looks like with a dermatoscope. Do any of you use a dermatoscope? Nobody. Jan, just think about this. At some future meeting, there's a good way to, in an hour, I can teach anyone how to use a dermatoscope. It might be fun to do. And we can get dermatoscopes and have people actually play with them. So dermatoscope is a handheld polarized light source. And when you put polarized light on the skin, you can kind of see right through it, and you can see the arrangement of what's going on down there. And even better, you can tell certain types of lesions from other types of lesions. So looking at this with a dermatoscope, that's the other picture next to her lip, what do you see? You see red. Those are blood vessels. So we know this is a blood vessel tumor, but if you just looked at it really quick, it looks black, looks like a melanin-containing tumor, looks like it could be a melanoma. So here's a melanoma in the small box and the dermatoscopic appearance of a melanoma. And that lesion doesn't look much different than the lesion on her lip, does it? If you just walk in and look at it quickly. But with a dermatoscope in approximately 1 microsecond, you know whether it's a melanin-containing tumor or whether it's a blood vessel-containing tumor. So you know this thing is benign. Okay, here's a hair loss patient, 65-year-old female, full scalp hair, good health. Her mother died 4.5 months ago from metastatic breast cancer. Her sister died 1 month ago in an auto accident. Is she happy? No. I walked in and she's sitting on the exam table. She has, can you see that's a baggie filled with hair? She did that on her own. And she's crying with this bag of hair in her lap. So, what are the first things you should do? Look at the hair. It's all telogen hair. Is it more than 50? More than 100? Yeah. So there's 230 hairs in the bag by my rough estimate, and they're all telogen. So what does she have? What's this called? Telogen effluvium. Effluvium is massive hair loss, and she's losing hair because of the fact that she is psychically upset. Remember, telogen effluvium starts about 3 months, 4 months after an event. Her mom died, then her sister died. That's a lot of psychic stress. And you see telogen effluvium, that's what we see postpartum hair loss. But you see it postoperatively. You see it post-physical trauma, like an auto accident. You see it post-psychic trauma. And it'll last for 3 to 6 months. It'll stabilize, and then it usually regrows over 6 months. So the whole thing is about a year. Now, she does have a telogen effluvium. Are there any blood tests that we might want to do just in case? What other things cause hair loss in a woman? Thyroid, iron. Hair loss in a woman, knee-jerk reaction. Check a ferritin or a serum iron, TIBC, and something to do with TSH or some other measure of thyroid function. I think TSH is a good screen. They're negative. Her primary care doctor had gotten an RPR, which I don't know, maybe not. But so we know the diagnosis, telogen effluvium. Treatment of choice is tincture of thyme. Do nothing. You can put topical steroids on here. You could give low-dose spironolactone. Basically, time will heal her wounds and time will heal her head. You squeeze a benign tumor, it does this. What's the diagnosis? Dermatofibroma. Most of these are arms and legs. They might be a little tender, but most of the time they're rock hard and asymptomatic, and the best thing to do is leave the suckers alone. They're very deep. You can excise them, but you're going to leave a scar. Okay, another really good case. 28-year-old male who's been itching for 4 months. He's lost 20 pounds, and he basically feels crappy. He says, I just don't feel good. He's presenting with this and a sore throat. He's not told anyone about the sore throat. He presents to derm because of this non-specific sort of itchy rash on his arms. Okay, before we say anything, I'm going to show you his throat. He has thrush, lost weight, itchy rash. What's your question? Well, he doesn't know his HIV status. What's your other question? Is he gay or is he an IV drug user? He's an IV drug user. He's HIV positive. And that's how he presented, with thrush and with a nonspecific itchy rash. Remember when we were talking about categorizing itch? Itch with a rash that you can diagnose. Itch with no rash, but a clear metabolic reason. Renal dysfunction, hepatic dysfunction, thyroid dysfunction. Rash, no rash, and we don't know what else to call it. And then there's the nonspecific sort of rash. And before you call it nonspecific, always remember nonspecific rashes on the face, chest, arms can be HIV. So you want to know someone's HIV status if they have an itchy rash that's relatively new in onset. And then you also should ask, how are they feeling? Have they lost weight? And what their demographic status is that might help steer you in that direction. He's actually doing pretty good now. Okay, what is this? We did not discuss this. Halo nevus, several of you got it. Excellent. So it's a mole, and we believe, and there's some good histologic evidence, that this is an immunologic attack against the mole. And as the body directs an immunologic attack against the mole, it kills some of the pigment-making cells around the mole, so you get this white halo around a mole. Is that mole malignant? Almost never. But one thing you do want to make sure is to look at the rest of their body and have the back of their eyes looked at, because they might be mounting an immunologic attack about a melanoma elsewhere. But the immunologic attack doesn't just attack the melanoma, it attacks anything that has melanin. So a halo nevus oven by itself, generally speaking, 99% of the time is a benign lesion, but you should survey the patient elsewhere for the possibility of melanoma. This is a young child, didn't have anything. Why this happens, we really don't understand. The best thing to do is just let it go ahead and implode. And it's interesting because the halo then usually disappears over time. The best treatment is no treatment. Yes?
I often refer my melanoma patient, in fact, almost always do, to the dermatologist for a good skin screening for their dermatoscope. Should I be referring them to an ophthalmologist too?
Actually, yes. They should have an eye exam. You know, most people have an eye exam. Well, if you wear glasses or contacts, you probably have an eye exam, and that includes a fundoscopic exam once a year. But there are people with good vision who don't. So yes, they should. Okay, here's another hair loss. This is the only history I didn't make up. It's not real. I made this one up. The patient's real, but the story's not. 22-year-old, full scalp hair, good health. He's a senior, second string tight end on Ohio State University's football team who has now this patchy hair loss on his scalp. All the rest of his hair is okay. What does he have? He has syphilis because he lives in Columbus, Ohio. Okay, now, this wasn't a second string tight end at Ohio State University, but he was a patient who presented to me, and with this patchy hair loss in his demographic age group, I did evaluate him for syphilis, and his RPR is 1 to 256. So this was the only thing he had. We're always usually teaching to look at the palms and soles. That's correct, but he had nothing on his palms and soles. He had no mucus patches in his mouth. He had nothing else, and this is just this patchy asymptomatic hair loss, and that can be a clue that someone has syphilis. So we know what it is. What stage is it? Primary, secondary, or tertiary? Secondary. Primary is the chancre, which goes away spontaneously. Secondary is the rash, and tertiary is many years down the road and can affect the heart, the brain, the eyes, and even the skin with destructive lesions. We don't see much tertiary syphilis anymore because people get antibiotics so often. Okay, and what would be the treatment of choice? What drug? Bicillin. Benzathine, long-acting penicillin. It's interesting, there's a nationwide shortage of benzathine penicillin, exactly when we're peaking with the incidence of new cases of syphilis. Wouldn't you just know it? Some states it's almost impossible to come by. Interesting. Okay, almost done. Asymptomatic, firm, deep-seated thing in the scalp. What's this called? A what cyst? It's not an epidermal cyst, it's a pilar cyst. Treatment, excise it if they want it excised. Okay, good case. Last case, I think. 75-year-old female. She resides in the self-care unit of a nursing home facility. So she's ambulatory, she can do self-care. She's been in good health. She's on no medicines, amazing, at 75, no medicines except for Miralax, that's her medicine. She complains of increasing and generalized itching for 3 months. You see her rash there. There's some more, sort of all over the place, right? Name 4 things you might consider. She's 75 and she's in a nursing home. Scabies, always. Itchy older people in a group setting, scabies, number 1. Pardon? Dry skin, she's 75, she might have dry skin and just she's itching herself to death. Age, what else? 75. Unusual cause of itching, but she's older. Internal cancer. Her age, have to think about it. And because of her age also, what's her mentation? Is she demented? Does she have Alzheimer's? Remember, a cause of itching, particularly in the elderly, brain tumors, strokes, even small strokes can do it. Alzheimer's, dementia of all kinds, any central nervous system abnormality can be associated with itching. Now, the other thing you might think about is drugs, except I've already told you she doesn't take any medicines, so it's not a drug rash. I don't think too many people are allergic to Miralax. Okay, so what happened? Those are the things to think about. So a neurologist came and saw her and everything was fine. Her blood work, absolutely fine. She's had a kind of workup, a reasonable workup for internal cancer, not because of this, but recently as part of a comprehensive evaluation. All that's negative. She's really not dry skin. So what do we need to do? Scrape. Now, here's the thing. In World War II, there was actually a British army doctor called Mellanby. And what he did is he lined up British troops who had scabies. Can you picture doing this? And he scraped On every person he lined up, he scraped every excoriation and every little crusted thing on their entire body. And he did this on 1,000 people. I guess that's how he spent the whole war, but that's what he did. And here's what he found. You'll never see that duplicated again. On average, the person who has scabies for the first time will have approximately 10 to 12 mites on their entire body. So it's not easy to find, even though you might have a widespread rash. It's 10 to 12. If they've had scabies before, they mount an immunologic attack against the mite so readily they have on average 5 to 6 mites. So it's not easy. You have to target where you scrape. Finger webs, wrists, around the areola in women, scrotum and glans penis if there are lesions to scrape. In men, you don't just scrape normal skin. You have to find something that's been crusted. So we found some on her fingers, and that's what her scraping shows, or her wrist, I'm sorry. So that's what her scraping shows. Do you see up at the top right-hand corner? That's the scabies mite. Down here are the eggs. That's scabies shit. It's called scibula. That's the pregnant female is having excrement while she's burrowing through the skin and laying her eggs. And there's the female up at the top. The males don't burrow. It's a sad, sad story. Men has fun with woman, men dies. Woman burrows through the skin. So there you go. There's the female. So that's scabies. 2 choices of treatments. 1 topical. What is it? Topical. Permethrin. Actually, it's permethrin. It's not a long E. It's permethrin. Permethrin should be done twice, 2 weeks apart. Oral, ivermectin, 200 micrograms per kilogram, done twice, 1 to 2 weeks apart. Which one's better? They're actually totally equal. There was a really, really, really good study done in, of all places, Iran. And they did everything for scabies versus everything else in pairs of 2s. 300 to 400 people in each group. It turned out ivermectin and permethrin were the best, but they were equal. You can also use ivermectin topically. A study just done in Egypt where they used 1% topical ivermectin, and they did it 1 or 2 times. One time they repeated it if the patient was still itching a week later. Most patients needed 2 applications. Topical 1% ivermectin. We actually have topical ivermectin in this country. It's called Soolantra, and it's indicated for rosacea. But if you're creative in your prescribing, you can get the rosacea topical drug, and unfortunately, it's intended to be used on the face, so it's a fairly small tube, so you got to give them 2 or 3 tubes, but they can put it all over their body, and they can do it 1 or 2 times, and it will work. I've done it. It's off-label, but it does work. Ivermectin or permethrin.
What's happened to Lindane?
Lindane essentially is gone because the manufacturer stopped manufacturing it. About 6 months ago, I believe. It was also interesting because lindane can be quite a neurotoxin if you ingest it. And even if you use it, some patients with ectoparasite or what they think is an ectoparasite put things on every day or 5 times a day, stuff like that. You can absorb enough topically if you abuse it to have neurotoxicity, including seizures and even death. So the state of California was unique in that they passed a law against even possessing it. The penalty for possessing lindane was worse than the penalty for possessing heroin. But it's gone now. The manufacturer has stopped making it. Okay, so, all right, almost done. I guess there were a few more. What is this? Milia, right? Deep-seated. What's the cause of this hair loss? Slick. Hair follicles are still there. What is this? I heard it somewhere. Nope. Not trichotillomania. You don't get that in slicks. You'll have hair regrowing. This is an immunologic disease, mostly in kids. That's alopecia areata. So the one with the patchy hair loss is a girl, the other one's a boy. Oh, which has a better prognosis? Which of these two? The girl. The less extensive, the earlier the age, the better. But in this case, the extent really dictates which one is worse. And then I just want to show you this. This is what's coming. So tofacitinib has been used orally, and it's also been used topically for treatment of alopecia areata, and it's dynamite. It's not approved. And if you try and give it off approval and without insurance coverage, it'll cost the patient about $40,000 a year. But once it's covered, especially when there's a topical form, we'll actually revolutionize the treatment of alopecia areata. No steroids, that's monotherapy, given tofacitinib orally. 6-year-old Korean, resides at home, acute onset, intractable itching right on that one spot. What do you think about on the face? What is it? It's tinea. What question do you want to ask? That's his kitten. Look at the kitten very carefully. See the hair loss? That's what happens in the animals, kittens and puppies. Usually it's not the adults. It's children, puppies and kittens, young animals. And they'll have fur loss as their manifestation. And sometimes they'll be scratching at it like it itches. Sometimes it's totally asymptomatic. And what happens is the kids like the feel of the fur on the face, and they'll hold the animal like this, and that's how they get it. So what do you do now? You treat him. You can give him any topical antifungal. What else do you have to do? The cat has to be treated. So you send the cat to the vet. It'll be about $150, and they'll give them a miconazole-containing cream or shampoo. So, brief story. I have a pair of identical twin girls, and we had a pet cat. And they used to like carrying the thing on their shoulder, putting their faces on it. And it's a sweet cat. But one of the girls came down with tinea. It was a kitten. One of the girls came down with tinea. And she wouldn't go to school. She was 13 years old. So I had to treat her like really, really quickly. Because I can't go looking like this, Dad. I'm not going to school. So I treated her topically. She got better in a few days, better enough to go to school. Now I'm left with the cat. So I dragged the cat to the vet. The vet gave me a prescription for Dermazole shampoo, which is a miconazole-containing shampoo. How do you shampoo a cat that's not been declawed? I still bear the scar from the scratch from that episode. And from then on, I told my twins, the cat's yours. You're taking care of it. I don't want anything to do with it. And from that, pretty much that episode on, the cat would never come near me. She lived to 21 years of age, though, so nice cat. Okay, we've talked about that. Okay, almost done. Routine physical exam. You see this. It's sitting there all by itself. What do? You need to biopsy. You need to think about that. That is an example of the ugly duckling, right? It's sitting there by itself. It's a little irregular in its outlines. Notice it has kind of two colors. There's a darker portion on the superior portion, lighter brown on the bottom portion. There are a few little V's, little indentations in there, notches, if you will. So you need to really worry about that. That needs to either be excised or biopsied. Ugly duckling, some mole that stands out, you need to worry about. Why did this woman lose hair? Traction. She has that fringe at the front, means she's pulling it back. The way to treat it, you're not going to grow the hair back, but to prevent it from getting worse, stop straightening, stop using chemicals, and don't pull your hair back. I believe this is the last patient. Okay, so this is an itchy patient in a nursing home takes drugs for rheumatoid arthritis. It's very itchy. Patient says 24/7, and those fissures are painful. What's the diagnosis? We've talked about this disease, but not this manifestation of the disease. Who said scabies? Somebody said scabies over there. You're right. This is crusted scabies, or it used to be called Norwegian scabies. It's not because people from Norway get this, or because there's some like super scabies mite that lives in Oslo. It's because it was first described in Norway. But we've dropped them because we're friends with the Norwegians. You know, we should call it Russian scabies, would be better. But this is Norwegian or crusted scabies. You don't see this in a normal host. You usually see it in someone who's immunocompromised or immunosuppressed. It's most common in HIV-positive patients in this country, but this patient was taking immunosuppressants for his rheumatoid arthritis. And the real problem with this, other than this be teeming with mites, this is every little flake has mites in it. This person is shedding scabies in the environment. The risk is really that. They get deep fissures, and those fissures are portals of entry for bacteria, and they die of sepsis. So that's the real problem with crusted or Norwegian scabies. I think I'm going to show you a couple other examples. There are a couple other different patients. Notice those fissures. She was HIV positive, and he was on steroids for, I can't remember why, but he was on steroids and something else, a couple of immunosuppressives. And they developed Norwegian or crusted scabies. Bad, bad, bad disease. And it's also highly contagious. In this instance, if a patient with crusted or Norwegian scabies has been in an exam room, the exam room should be hermetically sealed. And someone needs to go in there, clean it up a lot, because any flake that drops off is filled with scabies mites. So here's the other question. How long will scabies live off a human host with no blood meal? 2 weeks, roughly. You know, some could be a little longer, a little less, but it's about 2 weeks. Oh, I have one more. This is what? Black female. She's lost her hair, but she's got this scarring kind of look, and her hands ache. She's got lupus, right? And where else should you look for lupus? Face and ears, especially ears. If you have someone with a scarring hair loss, always look in their ears. And if you see areas of hyper and hypopigmentation in the ears, that's almost always an indication of lupus. So here's the last slide. This is Alice Roosevelt Longworth. She was the daughter of Teddy Roosevelt, the president. She ultimately she was a Republican, of course, because Teddy Roosevelt was a Republican, but she became ultimately a Democrat, and she was a strong advisor and supporter of John F. Kennedy. You see her holding the baby there in the middle picture? That was her illegitimate child from a liaison that she had with the married Republican senator from Idaho at the time. But she was an interesting, grand old, high society kind of lady, died in 1980. Here's what she did. Here's her philosophy. Fill what's empty, empty what's full, and scratch where it itches.